Yeah, please start. Thanks for coming and just starting.
Good afternoon, everybody. Thank you, Professor Renner and the team for giving me opportunity to present in this international forum. I'll be talking about scope of neuromodulation strategies in the management of bipolar affective disorder. My presentation will follow this outline. First, I will be talking about the overview of management of bipolar affective disorder. Then I will be talking about overview of various somatic treatment and neuromodulation treatment that are quite relevant for bipolar affective disorder management. Then I will be talking about evidences and comparisons and the scope of neuromodulation in the management of bipolar affective disorder. So coming to the overview of management of bipolar affective disorder. So when we talk about management of bipolar affective disorder or any type of psychiatric illness, may it be any form of medical illness, when we talk about management of a illness, the main goals of treatment usually remains achieving early remission, early resumption of work, getting functioning so that the individual will get the better functioning as early as possible, to resume the better quality of life, and to minimize the disability. These are the goals of management, may it be for psychiatric illness, may it be for bipolar affective disorder, may it be for any medical condition. When we talk about management bipolar affective disorder, the goals are usually to control the symptoms as early as possible, to preventing the relapse of further episode, to prevent suicide, to limit the disability, to optimize the functioning of the individual, and of course to deal with stigma, because stigma is associated with almost all the psychiatric illnesses, including bipolar affective disorder, and stigma is attributing to a lot of dysfunction in the individual level and the family level. So dealing with stigma is an important goal in bipolar affective disorder management. When we talk about pharmacological management of bipolar affective disorder, usually in a standard clinical practice, clinicians they initiate the treatment after making the diagnosis. Depending upon the response, a subsequent step usually goes to optimization of the dose of the medication. Even after optimization, if the individual is not responding adequately, then the subsequent strategy usually becomes switching to another medication, which will be beneficial for the patient. Even after switching, if the strategy is not working adequately and patient is not responding well, then usually clinicians consider augmentation strategies. Then failure of augmentation, subsequently the clinicians, they usually combine multiple medications together, multiple strategies together, that we usually call as multimodal management approach. So this is how the treatment ladder for bipolar affective disorder is also used. We talk about the various management options for bipolar affective disorder. Broadly, there are three things that we use for management of bipolar affective disorder. One is the pharmacotherapy, that is very commonly used, very widely practiced, stands basically on mood stabilizers, antipsychotic medications, and some augmenting pharmacotherapy. Second strategy can be psychotherapy, and the third strategy can be somatic treatment. And clinicians often consider pharmacotherapy in combination with psychotherapy or somatic treatment if the symptoms are quite serious enough or severe enough. So the latest guideline usually talk about pharmacotherapies, like in the management of bipolar affective disorder, people talk about what is the most suitable medication for acute phase of management, what is the suitable medication for maintenance phase treatment, which medications are more suitable for treating the manic episode, which medications are more suitable for treating the depressive episode. There are some broad spectrum medications that are effective in both acute phase as well as maintenance phase, in manic phase as well as in depressive phase. One of these medication is lithium, quetiapine, olanzapine. These medications are effective in both acute phase as well as in maintenance phase, both depressive phase as well as in the manic phase. So a lot of evidences exist regarding which medication is more effective, which medication is less effective, which medication is more tolerable, which medication is less tolerable with respect to the management of bipolar affective disorder. Other than that, in the recent decade, a lot of research is going on to target some newer receptors, like people targeted opioid receptors, various other serotonergic receptors, glutamatergic receptors, cholinergic, histaminergic receptors. So various molecules are developed in the, and various molecules are in the process of development in different stages of trial, targeting different spectrum of receptors. Even people are targeting endothelial reticulum mitochondrial activity, targeting those activities in the management of bipolar affective disorder. Even people are targeting the nitrous oxide, oxidative free radical scavengers are the molecules that are used in the management of various psychiatric disorders, including bipolar disorder. We all know that when there is recurrent of mood episodes, that leads to significant changes in the cognition, significant functional impairment, that also result in impairment of the resilience of the individuals. All these changes, clinical changes, concurrently happen with the biological changes in the brain. There are some inflammatory changes. Various inflammatory markers are raised when there are recurrent mood episodes. Oxidative biomarkers are raised in the brain when there is recurrent mood episodes. Mitochondrial and endothelial reticulum dysfunction happens. Channelopathies also happen. Cellular resilience gets altered. All these changes increases the vulnerability to stress and increases the risk of having another mood episode. So the vicious cycle goes on. Increasing vulnerability increases the risk of a mood episode. Again, all these clinical biological changes happen that further deteriorates the individual's resilience, individual vulnerability. So this is how the neuroprogression happens in bipolar affective disorder. Researchers, they identified there are some voluntary processes and there are some automatic processes that happen in patients with normal individuals, and these automatic and voluntary processes gets altered in patients with bipolar affective disorder. Particularly for the voluntary processes, the dorsolateral prefrontal cortex, ventrolateral prefrontal cortex are responsible. For automatic processes, dorsomedial prefrontal cortex, ventromedial prefrontal cortex, orbitofrontal cortex, anterocingulate cortex, these areas are basically responsible. So when an individual develops a depressive episode or a manic episode during the course of bipolar affective disorder, the voluntary process and automatic process, these areas are either hyperactive or inactive. Probably these areas, that's why these areas are potential targets of neuromodulation in the subsequent treatment plan. Now we can talk about the various neuromodulation techniques. If you talk about neuromodulation technique, the most ancient one is electroconvulsive therapy that was introduced in 1939, late 1930s for clinical purpose. Nearly took 40 years to get the US FDA approval for in the treatment of psychiatric disorders. In late 60s, transcranial direct current stimulation was introduced for the management of various psychiatric disorders. In late 90s, transcranial magnetic stimulation was introduced. The magnetic stimulus is used for modulating the neuronal activity. Subsequently, deep brain stimulation, an invasive technique, was introduced. Epicranial stimulation and magnetic seizure therapy were introduced subsequently. This is how the neuromodulation techniques are evolved over past several decades. So this graph basically shows the FDA approval status of various neuromodulation techniques for different psychiatric conditions, neuropsychiatric conditions. Late 1970s, electroconvulsive therapy was approved by FDA. Late 90s, vagus nerve stimulation was introduced for management of epilepsy. Deep brain stimulation was approved for management of essential tremor. In 2000 and subsequently, deep brain stimulation, RTMS, vagus nerve stimulation, they are used for clinical conditions like OCD management, depression management, and subsequently over past 2 decades, the various innovative techniques like deep transcranial magnetic stimulation, deep brain stimulation, magnetic seizure therapy, all these techniques were experimented in a lot of neuropsychiatric conditions, and they got approval for management of those conditions. So basically, when we talk about neuromodulation technique, it ranges from electroconvulsive therapy to magnetic stimulation techniques to transcranial direct current stimulation technique to vagus nerve deep brain stimulation technique, magnetic seizure therapy. Other than this neuromodulation technique, a lot of research is also happening with respect to use of ultrasound stimulation, thermal stimulation, photic stimulation of specific brain areas for the treatment of various neuropsychiatric conditions. We all know that these neuromodulation techniques, they have a spectrum of mechanisms by which they they benefit the individual. So if we talk about electroconvulsive therapy, several mechanisms has been explained, ranging from neurotransmitter correction to altering the blood-brain barrier permeability, to change the metabolic activity of various brain areas, to enhance the production of BDNF, to suppress the cortisol, hypothalamo-pituitary adrenal axis suppression, neuroplastic effect. These are various mechanisms explained for the therapeutic effect of electroconvulsive therapy. When we talk about transcranial magnetic stimulation, it mainly causes focal cortical neuromodulation. If you apply high frequency magnetic stimulus, then it causes neurostimulation. If you apply low frequency stimulus, it causes local inhibition. Similarly, if you talk about transcranial direct current stimulation, it causes again focal neuromodulation. Cathode placement causes cortical inhibition. Anode placement causes cortical stimulation. Vagus nerve stimulation, basically it causes modulation of various brain areas that are related to the vagus nerve nucleus, mostly locus coeruleus and brainstem areas responsible for mood regulation. They are modulated through vagus nerve stimulation. Deep brain stimulation is basically recommended for the treatment of OCD treatment and Parkinson disease, essential tremors. Other than this, it has been tried in various patients with bipolar affective disorder. It modulates the deep brain areas, the neuronal firing of the deep brain areas. Magnetic seizure therapy is having a very similar mechanism, which is quite close to the mechanism of electroconvulsive therapy. Let's talk about neuromodulation and management of bipolar affective disorders one by one. If we talk about electroconvulsive therapy in the management of bipolar affective disorder, as per the CANMAT guideline, electroconvulsive therapy augmentation is considered as a second-line management option for the management of type 2 bipolar depression. So usually the first-line management remains mostly related to pharmacotherapy, either lithium, olanzapine, fluoxetine combination, or quetiapine. They are the monotherapies, or they can be used for the first-line treatment. Electroconvulsive therapy is considered as a second-line treatment, as an augmentation to the ongoing pharmacotherapy. So mood stabilizers are the mainstay of treatment of bipolar affective disorder. Most medications that stabilize the depressive episode, they have a risk of causing switch to mania. And those who are controlling the manic episode, they may induce some depressive symptoms. So electroconvulsive therapy is an effective treatment modality which is having anti-manic property as well as antidepressive property. So it controls the manic episode, it controls the depressive episode as well. The limitation with electroconvulsive therapy is the effect is short lasting. You cannot give electroconvulsive therapy for quite long time. Though people have tried electroconvulsive therapy as a maintenance therapy once in every 2 weekly, once in a month for longer time to prevent the further relapse of the mood episodes. So mostly the effect of electroconvulsive therapy is acute and short lasting. If you want a long lasting effect, probably you need to consider maintenance electroconvulsive therapy is an alternative option to prevent the relapse of mood episodes. The studies related to short-term outcome with respect to ECT in patients with severe drug-resistant mixed affective episodes in patients with bipolar affective disorder. They estimated what is the response to electroconvulsive therapy sessions and what is the remission rate. Response rate is somewhere around close to 42%, whereas remission rate is somewhere around 30%. Patients they achieve remission after electroconvulsive therapy. So these are the patients who received an adequate trial of pharmacotherapy, psychotherapy, mood stabilizers, antipsychotics. But despite of all those treatments, the mood episode is refractory to treatment, and add-on electroconvulsive therapy is able to achieve remission nearly 1/3 of those patients. The researchers, they identified some risk factors. Who are those individuals who are non-responsive to electroconvulsive therapy? It is very important to know, because when you decide for electroconvulsive therapy, the expectation of the patient is very high that if I am going for electroconvulsive therapy, then it is quite obvious that I will be getting some more response. But if the patient is having comorbid OCD, if the baseline score of mania on Young's Mania Rating Scale YMRS is very high, if the length of the current episode is too long, then probably these individuals, despite of ECT augmentation, they may not have adequate response to this augmentation strategy. So it needs to be explained to the patient's family members, and it should be, the clinician need to be aware of this. So in treatment-resistant bipolar depression, people have tried conducting various RCTs where they considered electroconvulsive therapy as monotherapy versus algorithm-based pharmacological treatment. We have discussed about the standard treatment algorithm. People start with either first-line treatments, like if you are treating a depressive episode, bipolar depressive episode, the first-line treatment usually in most of the countries, they either prefer monotherapy of quetiapine or fixed dose of olanzapine fluoxetine. Many people, researchers, clinicians, they tried with lithium. As a second line of treatment, people may consider lamotrigine or other mood stabilizers. So this is how you start the treatment, you optimize the treatment. Depending upon the response, you switch to another treatment strategy. This is how the pharmacological algorithm progresses. So in this study, they compared the pharmacotherapy versus unilateral brief pulse electroconvulsive therapy. And the effect was monitored till 6 weeks as an acute response. In this study, they found that the remission rate in both of the treatment groups are not significantly different. Those who are receiving pharmacotherapy and those who are receiving electroconvulsive therapy alone, they have a similar kind of remission rate. But the response rate of electroconvulsive therapy group is significantly more than 2 times higher than that of pharmacotherapy group alone. So individuals who are receiving electroconvulsive therapy, they are more likely to respond acutely than those who are receiving pharmacotherapy alone. Response rate to electroconvulsive therapy has been compared with unipolar depression versus bipolar depression. The response rate is quite similar. Individuals with unipolar depression, individuals with bipolar depression, they have almost similar rate of response. But those individuals who are having a bipolar depression, they show the response bit earlier. So unipolar depression probably require more number of sessions of electroconvulsive therapy to get a response, whereas bipolar depression patients, they respond within a relatively less number of sessions of electroconvulsive therapy. Meta-analysis that included 6 studies where the unipolar depression patients are 790, whereas bipolar depression patients are 316. This study found that the response rate to unipolar depression is around 51%, whereas response rate to bipolar depression is somewhere 53%, which is very close It indicates that electroconvulsive therapy is a useful treatment strategy for management of both unipolar depression as well as for bipolar depression with equal effectiveness. Researchers attempted to use electroconvulsive therapy in an elderly population with more than 65 years of age with bipolar depression. It was found that there is significant reduction of the depressive symptoms, and at the same time, because elderly population, they are very much concerned about the cognitive functioning. The cognitive reserve of the elderly population is relatively less in comparison to the adult population because of the aging process and ongoing bipolar affective disorder that is also affecting the cognitive process. They found that there is improvement in the depressive symptoms and there is at the same time improvement of the cognitive function. Electroconvulsive therapy is known to have cognitive side effects. Despite of that, this study found that there is improvement in the cognitive functioning. And most of the patients, they tolerated the therapy well with no noticeable side effects. So electroconvulsive therapy can be considered as a safer option for the treatment of severe mood episodes and mood episodes in the elderly population. Electroconvulsive therapy was also tried in special population like pregnant females and particularly those who are having severe episodes of mania and bipolar depression. Pregnant females with bipolar depression and severe episodes of mania, they responded well to electroconvulsive therapy and they tolerated well to electroconvulsive therapy. So there is no pregnancy related complications in most of the patients. But what is important in dealing with the pregnant females with bipolar depression or bipolar manic episodes, we are planning for electroconvulsive therapy for the utmost safety of the patient. There is a need of interdisciplinary coordination, particularly with obstetricians and pediatricians to take care of if there is any complication arises during the course of treatment. We can take support from those other department colleagues. So now talking about transcranial magnetic stimulation in bipolar affective disorder management. Researchers, they estimated the cortical excitability in patients with mood disorder. To estimate the transcranial magnetic stimulation is one of the technique by which you can estimate the cortical excitability. You estimate the resting motor threshold, and that is an indicator of what is the excitability of the cortical neurons. So interhemispheric asymmetry in the cortical excitability is seen in patients with bipolar affective disorder. Variation in cortical excitability in patients with is observed in patients with who are having symptomatic affective episodes like manic episode, those who recently remitted from the affective episode, and in the healthy subjects as well. The motor threshold in remitted first episode manic patients, it reflects that if you treat these mood episodes with pharmacotherapy or neuromodulation, the motor threshold becomes lower. So it corresponds with the therapeutic response. So if you alter the cortical excitability through neuromodulation, probably you can bring a therapeutic response. In a retrospective analysis, patients with bipolar depression, both type 1 bipolar and type 2 bipolar, they are included. They attempted with high frequency RTMS. High frequency RTMS is known to produce stimulation of the underlying neurons. So they have given this high frequency RTMS at 120% of the resting motor threshold over the left dorsolateral prefrontal cortex. 3,000 pulses were delivered for 30 sessions. This is the FDA approved protocol for the management of depressive episode by using RTMS. So this protocol was used. Patients who are enrolled for in this study, they already received pharmacotherapy for depression, either in the form of one or more mood stabilizers without any antidepressants. So they have received these multiple failed attempts of pharmacotherapy before enrollment to the RTMS trial. At the end of 25 sessions of RTMS, these sessions are delivered on daily basis, 1 session per day. So 5 sessions in a week, At the end of 5 weeks, 25 sessions are delivered, and the response rate is somewhere around 41%. But at the end of 6 weeks, when 30 sessions are delivered, the response rate is almost double. So more number of response, more rate of response is elicited if you give more number of sessions of RTMS. So probably individuals with treatment refractory bipolar affective disorder, they require more number of sessions to have a better response. RCTs, they evaluated the safety and efficacy of deep RTMS. Deep RTMS is a specialized form of RTMS where the penetrability of the magnetic stimulus becomes more. In a conventional RTMS, when you use it, the penetrability is somewhere around 3 centimeters. When you use deep RTMS, deep TMS, the penetrability goes up to 5 centimeters. So conventional RTMS is only effective for modulating the cortical activity of superficial cortical neurons, whereas deep TMS may be able to alter the cortical activity of superficial cortical neurons as well as deep cortical neurons. And the volume of stimulation, neurons, volume of brain area that is stimulated by DTMS is much higher than the volume of brain area that is modulated by conventional RTMS. So researchers, they use deep TMS in the treatment of resistant cases of bipolar affective disorder. Those individuals who are receiving active TMS, there is significant reduction of the depressive symptoms than those who are receiving the SAM treatment. And they estimated the response. They followed the patients for another 4 weeks to see whether the response is sustained over a period of time. But unfortunately, whatever improvement achieved during the initial part of the treatment, it is not sustained. It indicates that the therapeutic benefits that you get from RTMS are again huge. And if you want a sustained benefit, probably you require maintenance RTMS for the management. In this study, they found that the response rate of individuals who receive active RTMS, it is around 48%, whereas those who receive SAM TMS, it is half of that, that is around 24%. Recent systematic review and meta-analysis that included 56 randomized controlled trials with patients more than 3,000 adults with unipolar and bipolar depression. It evaluated the efficacy and acceptability of various non-invasive brain stimulation technique, including TMS, transcranial direct current stimulation, and theta burst stimulation. It is found that high frequency RTMS over left dorsolateral prefrontal cortex is having the highest level of evidence in terms of efficacy when you are treating the depressive episode, may it be unipolar depression or bipolar depression. So high frequency RTMS is having the highest level of efficacy. Those who are receiving intermittent theta burst stimulation, there is some improvement in reducing the treatment duration. The pharmacotherapy required, the drug requirement becomes less, the treatment duration becomes less, but the improvement is not substantial like the high frequency RTMS. If you are using continuous theta burst stimulation or bilateral TBS, these strategies are not much effective in the treatment of unipolar and bipolar depression. When we talk about the manic episode management, most of the studies that use RTMS for treating the manic episodes, they usually target the right dorsolateral prefrontal cortex. Those who are treating the depressive episode, they basically target the left dorsolateral prefrontal cortex. So left dorsolateral prefrontal cortex stimulation is required for the treatment of depressive episode. Right dorsolateral prefrontal cortex stimulation is required for the treatment of manic episode. So patients receiving high frequency RTMS over the right dorsolateral prefrontal cortex, they show significant reduction in the manic symptoms at the end of therapy. So for the treatment of the manic episode, safety and efficacy of accelerated RTMS protocol has been tried. So accelerated RTMS protocol is a modification in the conventional protocol A conventional protocol of RTMS usually says that you give one session of RTMS on daily basis. You call it accelerated RTMS protocol when you give more than one sessions of RTMS per day. So in this scenario, they have given 30 sessions of RTMS over a period of 15 days. It means that 2 sessions of RTMS given in a given day. So high frequency RTMS over left dorsolateral prefrontal cortex is given 30 sessions over 15 days. Patients who are more than 60 years of age, they had significant higher rate of remission and response than those who are less than 60 years of age. If you refer to the research published a decade back, most of the research they say that geriatric population are usually the poor responder to RTMS. The reason being, as the age increases, the cortex becomes atrophied. The atrophy of the cortex causes increase in distance between the cortical surface to the skull surface. So the penetrability is of only 3 centimeters and cortex is sinking. So the stimulus that is given by the RTMS coil is not reaching the cortical surface. Probably that is why the elderly individuals are not responding. This is the explanation given by the studies, most of the studies published a decade back. But the recent evidences support that even after cortical atrophy, elderly individuals, if you give high frequency RTMS, they can have a higher rate of remission response rate even than the individuals who are receiving, adult individuals who are receiving the RTMS for the treatment of depression. So older population can show significant improvement to anxiety and depressive symptoms when you give RTMS stimulatory protocol, high frequency RTMS over the left dorsolateral prefrontal cortex. Comparison between whether the individuals with type 1 bipolar, they respond well to RTMS, or those who are with type 2 bipolar, they respond well to RTMS. Some early evidences report that patients with type 1 bipolar disorder are having a better response to RTMS than those individuals with type 2 bipolar. The response rate, remission rate in type 1 bipolar rate is higher than type 2 bipolar. But it is also reported that type 1 bipolar patients, they also report more adverse effect to RTMS than type 2 bipolar disorders. So therapeutic effect and adverse effect go concurrently. Response in unipolar depression was also compared with bipolar depression. Response rate to RTMS in bipolar depression is significantly lower. It is found in a study published in 2021. Individuals with bipolar depression, they have a lower response rate than unipolar depression. However, similar kind of study was conducted in the subsequent year. That is also having a contradicting finding. Patients with bipolar depression, they have a better remission rate and response rate than patients who are having a unipolar depression. In unipolar depression, the response rate is somewhere around 40%, whereas in bipolar depression, the response rate is double, somewhere around 80%. In unipolar depression, the remission rate is somewhere around 15%, whereas in bipolar depression, the remission rate is 3 times higher, around 45% have a remission rate. So we are getting some contradicting finding whether unipolar depression patients are responding better to RTMS or bipolar depression patients are responding better to RTMS. So both the studies are recent studies, but there is a difference in the sample size. The first study is having a very smaller sample size, whereas the second study is having a relatively larger sample size. So we need to have further studies in a very larger sample size with follow-up for a longer time to establish the fact whether unipolar depression is responding well to RTMS or bipolar depression is responding well to RTMS. Let's talk about transcranial direct current stimulation in bipolar disorder management. Randomized control studies exist with response to use of tDCS in the management of bipolar disorder. So it is tDCS is basically used along with the pharmacotherapy. Most of the patients were receiving mood stabilizer in one mood stabilizer. So tDCS is given in one group who is receiving mood stabilizer. The other group is giving medications alone. tDCS was not given. So they have two arms. One group is having pharmacotherapy plus tDCS. Second group is having pharmacotherapy alone. So it was found that combination of tDCS with pharmacotherapy, these patients are responding well to this treatment strategy. They have a higher reduction of the depressive symptoms in comparison to those who are receiving medication alone. They did a follow-up for 3 months and they found that again the benefits are not sustained. May it be electroconvulsive therapy, may it be TMS, may it be tDCS. The benefit that we are getting, they are mostly acute benefits. The benefits are not sustained over a period of time. This indicates that probably individuals who are receiving these neuromodulation techniques, they require some maintenance sessions in order to have a sustainable benefit. This study also concluded that those who are receiving tDCS with medication, they have less cognitive deficits than those who are receiving medications alone. Again, this study is limited because of has several limitations because of the small sample size, shorter intervention. Only 10 sessions were given in 5 days period. So usually, if you think of pharmacotherapy, it takes around 2 to 3 weeks time for the onset of action. And you have given in this study, researchers, they have given tDCS intervention for 5 days only. 2 sessions in a day over a period of 5 days. So probably this intervention period is shorter. So subsequent research may try with a longer sessions of more number of sessions and longer duration of tDCS to see whether the benefit is more or not. A trial that is better trial, bipolar depression electrical treatment trial. This is an ongoing trial. A lot of publications are coming from this better trial. Those individuals who are receiving active tDCS, they have placement of anode over the left dorsolateral prefrontal cortex and placement of cathode over the right dorsolateral prefrontal cortex. So tDCS is bit more beneficial, I will say, more superior than TMS, I will say, because in RTMS you will use RTMS placement of coil is only targeting one brain area. When you are using tDCS, you have option to manipulate 2 cortical areas simultaneously. There is a placement of cathode, there is a anode placement. Anode placement causes stimulation, cathode placement causes underlying cortical inhibition. So in this case, simultaneously left dorsolateral prefrontal cortex was stimulated and cathode placed over right dorsolateral prefrontal cortex, which inhibited the right dorsolateral prefrontal cortex. And 1 session is given per day, and 10 sessions were given over a period of 2 weeks. And subsequently, over next 4 weeks, same protocol was given every 2 weekly. So a total of 12 sessions were given, 10 sessions on daily basis, then 2 sessions over next 4 weeks, every 2 weekly. A total of 12 sessions were given. So 10 sessions are acute treatment and 2 sessions are maintenance treatment. So there is a significant improvement in the depressive symptoms in the group who is receiving active tDCS in comparison to those group who are receiving sham tDCS. This trial, the team, they have published another paper in 2021. They estimated also the possible association of inflammatory biomarkers and response to tDCS and bipolar depression. Individuals who are receiving tDCS treatment, active tDCS treatment, there is a significant fall of interleukin 6 levels. So they found that if an individual with baseline increased interleukin 6, it is a predictor of response to tDCS. Those individuals have a higher level of baseline increase in interleukin 6. They respond well to tDCS. The side effects associated with tDCS are very minimal and well tolerable. Risk of switch to mania is quite rare. The common side effects associated with tDCS are tingling sensation or numbness in the area where the electrode is applied or headache. These are the common side effects associated. Recent open level study that used tDCS in patients both with unipolar depression and bipolar depression. And these patients, they have received one failed medication trial before getting enrolled to the tDCS. 10 sessions were delivered over a 5 days time. Anode is placed over left dorsolateral prefrontal cortex and cathode is placed over right dorsolateral prefrontal cortex. At the end of the therapy, the patient group who received active tDCS, they have significant improvement of cognitive symptoms, depressive symptoms, as well as anxiety symptoms. Another study that pulled the data from 3 different studies evaluated the efficacy of tDCS in major depression, that is both unipolar depression and bipolar depression. The improvement of the depressive symptoms in unipolar bipolar depression are quite comparable. We found similar kind of findings in PMS studies. Unipolar depression and bipolar depression, they respond early, but the response rate is quite comparable. Patient with cognitive deficit, psychomotor retardation, anxiety, prominent somatic symptoms are probably respond better to tDCS. We can say that these are the clinical predictors of response to tDCS. So a clinician who is planning for tDCS augmentation for bipolar depression or unipolar depression, so these are the potential candidates. Those who are having cognitive deficits, prominent cognitive deficits, psychomotor retardation, anxiety, and prominent somatic symptoms along with the depressive symptoms, they are more likely to respond to tDCS treatment as an augmentation strategy. Possible role of tDCS in some newer areas, new target areas like left ventrolateral prefrontal cortex has been tried. Patients with bipolar disorder, left ventrolateral prefrontal cortex shows unusual higher activity during the reward anticipation. So when you are giving a reward or the individual is anticipating a reward, there is a hyperactivity of left ventrolateral prefrontal cortex. And this left ventrolateral prefrontal cortical activity is significantly unusually higher in patients with bipolar affective disorder. So if you modulate the cortical activity, you reduce the higher cortical activity in this particular area by targeting it through either TMS or tDCS, then probably you can bring therapeutic changes. So cathodal tDCS over this site is found to be effective in reducing the hyperactivity of this area, which can have potential role in management of bipolar affective disorder. A systematic review that included 19 studies, including 170 patients, they used tDCS in the management of bipolar affective disorder. Out of these 19 studies, 10 studies, they report that tDCS is effective in reducing the depressive symptoms. 4 studies, they reported that there is a beneficial role of tDCS in improving the neurocognitive deficits, improving the neurocognitive performance in patients with bipolar disorder who were even euthymic. They are recently achieved remission. Out of these 19 studies, there is one case report. This demonstrated the beneficial effect of tDCS on the manic symptoms. Rest 4 studies, they were quite inconclusive about the role of tDCS in the management of bipolar affective disorder. Transcranial random noise stimulation is a newer form of it's a form of transcranial direct current stimulation only. Here the electrical current is not going in a static manner. It is going in a arbitrarily fluctuating manner. So we call it a electrical noise. So transcranial random noise stimulation is used in the treatment of depression, both unipolar depression and bipolar depression. Anode is placed over the left dorsolateral prefrontal cortex and cathode is placed over right dorsolateral prefrontal cortex. Patients, they received 20 sessions of RNS over a period of 4 weeks, daily 1 session. There is no significant difference in the response rate and remission rate, those who are receiving active and those who are receiving SAM tRNS. So it indicates that tDCS is effective, but if you are planning for tRNS, it may not be so effective. So probably require more number of studies to establish whether tRNS is having a beneficial effect in management of bipolar affective disorder. Vagus nerve stimulation has been attempted in patients with bipolar affective disorder management. The researchers, they use vagus nerve stimulation in the management of bipolar depression. Improvement in the depressive symptoms in both unipolar and bipolar depression, they are not significantly different. So vagus nerve stimulation causes improvement of the depressive symptoms both in unipolar depression as well as in bipolar depression, and the response rate is quite similar. I will tell that the patients who are included in vagus nerve stimulation studies, they are mostly limited by small samples. A study that conducted over 9 patients with rapid cycling bipolar affective disorder over a period of 1 year. These are the treatment severe depressive episode patients, and most of the patients are having treatment refractoriness. After vagus nerve stimulation, the response rate, these difficult to treat patients, they have 38% reduction of the severity of the depressive symptoms over a course of treatment of 1 year. Treatment-resistant bipolar patients has been tried with vagus nerve treatment, and significant reduction of depressive symptoms and suicidality has been noted over a period of time. So when one need to consider about vagus nerve stimulation, one need to confirm the primary diagnosis of major depressive disorder, may it be unipolar depression or bipolar depression. The current mood episode should be a longer episode, or there should be more than 3 previous episodes. And to consider vagus nerve stimulation, either the patient should have received a trial of electroconvulsive therapy, but at the end of electroconvulsive therapy, the patient relapsed, requiring maintenance electroconvulsive therapy. If electroconvulsive trial was not given, then probably the patient must have received at least more than equal to 2 trials of psychological interventions, out of which one should be in combination with pharmacotherapy, or there should be at least more than equal to 4 antidepressant failed trials, or there should be at least more than equal to 2 augmentation strategies adopted, like augmentation of antidepressant with either mood stabilizer like lithium, or antipsychotic like quetiapine, aripiprazole, or risperidone, or the patient has received 8 sessions of ECT. Then you may think of, despite of all these strategies, patient had longer hospitalization, repeated hospitalization for more than 6 months. So these are the group of patients who are adequately treated with multiple modalities of treatment, refractory to treatment, difficult to treat. Then probably these are the indications of vagus nerve stimulation. You need to exercise cautions when considering vagus nerve stimulation. Rule out personality disorder. Look for whether there is an active substance use. Rule out comorbidities like psychosis, compromised mental capacity. All these things need to be addressed before going for vagus nerve stimulation. Magnetic seizure therapy has been tried in patients with bipolar affective disorder. It's another neuromodulation technique where magnetic stimulation is given in very high frequencies that produces seizure, and it is considered as an alternative to electroconvulsive therapy. Open label study in patients with bipolar depression using magnetic seizure therapy. The remission rate is somewhere around 30% and response rate is somewhere around 50% who completed the treatment protocol. Again, I will say that though these refractory bipolar depression patients respond well to magnetic seizure therapy, again, these effects are mostly acute. People tried it with adolescents with depressive symptoms, adolescents with bipolar depression. People tried it with the elderly population too. tried it with unipolar and bipolar depression too. So systematic review that included 8 studies, including both unipolar and bipolar depression, they found that the response rate is ranging between 30 to 40%, and it is mostly well tolerated and having a better cognitive functioning in comparison to electroconvulsive therapy. Those who are receiving electroconvulsive therapy, they have more cognitive side effect. Those who are receiving magnetic seizure therapy, they have lesser cognitive side effect. Though there is no head-to-head trial comparing the therapeutic efficacy and cognitive benefit between magnetic seizure therapy and electroconvulsive therapy in patients with bipolar affective disorder. Again, these studies, they have a limitation of a small number of bipolar depression patients are included in these studies. In a recent study, magnetic seizure therapy was used as a maintenance treatment of treatment-resistant unipolar and bipolar depression. The 12 booster sessions are given over a period of 6 months. So every 2 weekly, one session of magnetic seizure therapy is given after delivering a session of acute treatment of mood episode with magnetic seizure therapy. It is found that nearly 2/3 of the patients, they reported significant improvement of their depressive symptoms. So whatever neuromodulation technique you consider, probably you need to consider about maintenance sessions, because most of the benefits are acute benefits. Invasive technique like deep brain stimulation has been attempted in patients with bipolar affective disorder. Significant improvement is reported in the depressive symptoms. Obviously, there is a risk of switch to mania or hypomania is there, but the risk of switch to hypomania or mania is a rare phenomenon. Some important cortical areas, deep cortical areas has been identified, like bilateral subcallosal cingulate cortex, superolateral branch of the median forebrain bundle. They are identified as the important target areas for deep brain stimulation, the management of depressive episode. So DBS has been attempted in sense with unipolar depression and bipolar depression. The efficacy is almost similar. This is what the preliminary evidences say. Safety efficacy of DBS has been tried on the new target, that is central antral limb of the internal capsule. This is the common target that is recommended for the management of OCD. Even patients with Parkinson's disease, even patients with essential tremors, this VALIC is the target area. So 5 patients with OCD with comorbid bipolar depression. This is a very difficult to treat condition when OCD and bipolar affective disorder are comorbid together. After DVS, it is found that there is significant reduction of the OCD symptoms as well as depressive symptoms. In this study, they found that the risk of switch to hypomania and mania are very high. So it is a transient phenomenon. I will say that individuals with OCD, they usually need a relatively higher dose of anti-obsessive medication like serotonergic medications. Probably that increases the risk of switch to mania if it is in the context of a bipolar affective disorder. So that might be the reason why there is a relatively higher risk of switching to hypomania or mania. So it is a transient phenomenon. So there are some final concluding slides to summarize. Magnetic seizure therapy, transcranial alternative current stimulation, transcranial random noise stimulation, auricular stimulation, trigeminal nerve stimulation. These are some important neuromodulation technique that has been tried in human population. Optogenetics, thermal, chemical, sonic stimulation are mostly in the animal studies, where we are yet to have some large robust evidence regarding its use in management of bipolar affective disorder. Among the newer neuromodulation technique, magnetic seizure therapy, transcranial auricular stimulation, trigeminal nerve stimulation, random noise stimulation, they are found to have some role in benefiting the depressive mood episodes. So probably these are the future areas. Subsequent further intensive research is required in a larger population to see whether transcranial random noise stimulation, auricular stimulation, or trigeminal nerve stimulation is useful in bipolar affective disorder management or not. This is an interesting article published in British Medical Journal 2019. This compared the efficacy and acceptability of non-surgical, that is non-invasive brain stimulation technique for the acute treatment of major depressive episode in adults. That included both unipolar depressive episodes as well as bipolar depression, patients with bipolar depression. They did a systematic review and network meta-analysis. The interesting findings are, you see that risk of bias is high in only 17% studies. There is low risk of bias in nearly 1/3 of the studies. So bias studies are very less. They found that the response rate is, if you are treating a affective episode, depressive episode, may it be unipolar depression or bipolar depression, and you are using a neuromodulation technique, then probably will get a higher response rate if you are using electroconvulsive therapy, preferably over bitemporal electroconvulsive therapy than bifrontal electroconvulsive therapy. Even RTMS is also having a beneficial role in terms of response rate is considered. Priming, if you are doing a priming, before priming is usually researchers, they do so priming by giving 6 Hz. It's a high frequency RTMS, 6 Hz frequency, 600 pulses per session. So you do a priming by high frequency RTMS, then you give low frequency RTMS. Once you prime the cortex, then by high frequency RTMS, then give low frequency RTMS, then probably when you give priming, it causes stimulation of the glutamatergic neurons. So it potentiates the effect of GABAergic activity that is induced by the subsequent low frequency RTMS. So priming facilitates the low frequency RTMS efficacy. So recently researchers, they are using priming technique before giving low frequency RTMS. So if you are doing priming or giving bilateral RTMS, or you are giving low frequency RTMS on the right side or high frequency RTMS on the left side, that is beneficial for the therapeutic effect. That is having a high response rate. If you are using theta burst stimulation, then probably bilateral theta burst stimulation or intermittent theta burst stimulation is more effective in terms of therapeutic response. Other evidences suggest that tDCS and magnetic seizure therapy may be effective, having a relatively high response, but the highest level of response is with electroconvulsive therapy followed by RTMS, particularly low frequency RTMS over right dorsolateral prefrontal cortex or high frequency RTMS over left dorsolateral prefrontal cortex. So this forest plot of this interesting meta-analysis suggests that response rate is highest with bitemporal electroconvulsive therapy and response rate is lowest with continuous theta burst stimulation. When we talk about cause discontinuation rate, particularly when you are giving low frequency RTMS, that is having a less discontinuation rate. When you are giving bilateral theta burst stimulation, that is having a relatively higher discontinuation rate. So here I will summarize that neuromodulation technique